Let's see. Okay. So I'll post in the chat the link to the cases that we're going to talk about to begin with. And then I think Esther and perhaps Mini also have a few cases to share. Um, I think most of you are in the GYN module. And one of the hard areas in pathology and GYN pathology in particular, is frozen section. So we thought we would take a few minutes today and talk about one of the more challenging areas, which are ovarian frozen sections. So I've posted the link to the slides, and we will go through these. These are also included in the GYN module, um, but I believe it's module 2 before you would get to this topic. So we're going to give you a little advanced preview of that and talk about this. So one of the first things to think about, of course, is why are we doing this frozen section? And of course, surgeons have many reasons to request a frozen section, but in the ovary, there are some particular concerns because it's very difficult to biopsy the ovary preoperatively. And so being able to differentiate benign from malignant is oftentimes a very important distinction because that will govern the extent of surgery, the extent of sampling. At the same time, there are many instances where metastatic disease can mimic a primary ovarian tumor, and the workup and evaluation of metastatic disease in that setting of a large, bulky ovarian mass is quite different. So those are the two major considerations in frozen section. Uh, but growing out of that comes additional information such as, do we have enough tissue? Is it viable tissue so that we can get a final diagnosis? And what is the likely pattern of spread going to be for this tumor? And therefore, what needs to be done in terms of staging? This also can alert the surgeon to the potential need to sequester blood for serum tumor markers and so forth at an early point before the tumor markers have fallen back to zero or something of that sort. So that those are all reasons to be thinking about when you're doing a frozen section. What you need to be communicating is not necessarily the specific subtype of ovarian cancer, but rather the category that it falls in. Is it malignant? Is it a common epithelial tumor? Is it metastatic disease? Those sorts of questions are the main considerations that you have. Of course, governing that will be um, things that help you then later on as you determine what additional sections may be needed, what additional special stains may be needed. And also, this can be a great benefit to communicate with the surgeon about what they see in terms of extent of disease and so forth. Recognizing that nodal evaluation may differ for different situations as well. This can be very, very important to help you as a pathologist. So what is going to lead them to do further biopsies and staging of the tumor at the time of surgery? Well, any of the common epithelial tumors or borderline tumors will lead to additional staging biopsies. Likewise, several of the sex cord stromal tumors like granulosa cell or Sertoli Leydig tumors may require staging evaluation. Usually a fibroma or fibrothecoma does not, but there are certain of the sex cord stromal tumors which you need to be at least thinking about or raise the possibility of if you want them to do further staging biopsies. Likewise, germ cell tumors and immature teratoma can often benefit from staging evaluation, and so those are things that they need to be aware of. I find it very helpful to think in terms of age groups. Younger patients, there's a list of things here that are more commonly seen in younger patients: germ cells, X-cord stromal tumors, low-grade serous tumors, and so forth. And also occasionally these high-grade small cell tumors. And then older patients are more likely to have the common epithelial tumors, metastatic tumors, even some undifferentiated or dedifferentiated tumors, and endometriosis-derived tumors as well. So those are all considerations that may guide you in your evaluation. Knowing the age and the clinical presentation is very helpful. Then once you're got the tumor in your hand, there are several patterns, and I think these are also something that I find very useful in evaluating an ovarian tumor. And so we're going to sort of divide some of the things that we look at today in terms of these patterns: the solid tumors, mixed solid and cystic, the more fleshy, friable tumors, gelatinous tumors versus just heterogeneous patterns of variable sorts of things. So here's the solid pattern. When we think of that, we think of, you know, fibrothecomas or fibrosarcomas, very uncommon, and metastatic tumors, some sex cord stromal tumors, maybe smooth muscle tumor, also a benign condition like massive edema of the ovary can present in this sort of a pattern as well. So here's our first case. And if you've pulled it up, you can take a look at this. This is, as you see, got some blue areas, some slightly edematous areas. And as we come in to evaluate this, we also see that there's some follicle-like spaces here. So there might be some sort of microcystic pattern that we might think of. Does anyone want to take a guess as to what category of tumor this might fall into? Is this a common epithelial tumor? Is this a germ cell tumor? I haven't told you the age, of course, but what would you be thinking of here? Notice how it has some nesting, maybe a little bit of falling apart here. This is an actual frozen section slide, so it's not high quality. But notice that many of these islands or groups have sort of a peripheral lining up of some of the cells. Does anyone want to take a guess?
My guess is epithelial.
Okay, so it is more epithelial than stromal, that's for sure. Do you think this is a benign tumor or a malignant tumor based on the morphology? Quite uniform cells.
Is there any like pseudo rosette patterns in there?
That's a good question because that would make you think of immature teratoma or something like that. I don't think we really have rosettes here, but you're heading in the right direction because this is technically, I think, what is referred to as a monodermal teratoma in the sense that it's a neuroendocrine tumor, which is oftentimes categorized in that grouping of monodermal teratomatous lesions. So this is probably a neuroendocrine tumor of the ovary. It may or may not have thyroid elements in them, but could be seen as part of a teratoma or as a standalone tumor. Vanita, I see you've joined us. Do you have any thoughts on this tumor? Unmute.
Uh, I, I
Sorry.
guess I guess it would be granulosa cell tumor.
So granulosa cell tumor is definitely in the differential, and you may not be able to make that distinction on frozen section. You're very correct there. Vanita, go ahead.
So I guess first, as to how I would describe this tumor, to me, there's a nested trabecular sort of appearance, and all of the nests seem to have sort of peripheral palisading, and then in the closer up, you have this. Somebody used the word pseudo rosette. There seems to be this organization, at least in some areas, where you have the cells are at the periphery. You're just coming up on something that looks like either a small gland. To my on my screen, I'm seeing it at about 5 o'clock. So for me, the differential diagnosis here is three things come to mind. One would be a carcinoid tumor, either primary or metastatic. The second thing I would think of is, as one of our participants said, a granulosa cell tumor, because those rosetting sort of things do have a resemblance to call Exner bodies. And the last thing I would think about, I think one of our participants also said, was an epithelial tumor, like an endometrioid tumor, but with, the sex cord-like differentiation ones, they can have these smaller formations that sort of overlap. So I'm sort of in the differential of, carcinoid, primary ovarian carcinoid, or if it was metastatic, it would be neuroendocrine tumor. And then granulosa cell tumor is my second choice. The epithelial one is my last choice. So that's where I am. And you hinted that there might be thyroid elements in here. So that makes me think of a monodermal, either carcinoid of the ovary or stromal carcinoid, depending on whether we find those thyroid-like elements.
Yeah, now typically in frozen section, we only get probably 2 or maybe 3 blocks if we're being really generous. And so we have to be very selective in what we sample. But I think the information that we've gathered here is probably enough to tell the surgeon what they need to do next. We've told them what our considerations are, and really almost all of those would entail some search for additional information or additional staging data on this patient. So good discussion. Let's go on and take another example here. Another solid tumor. And this is obviously got some more bluish cells, some dark pink areas. And as we come into higher magnification, I think you can see that these pinkish areas are quite collagenous. And then the cellular elements not really forming epithelial structures per se. So what category of tumor do we think we're dealing with in this situation? V, do you want to pose a supposition? Does this look like an epithelial tumor?
No, it's not look like an epithelial tumor.
So what category would you think this most likely fits into?
I don't know.
Well, the categories of ovarian tumors are, common epithelial tumors, sex cord stromal tumors, germ cell tumors, and then kind of other categories.
I think also a big hint is this really thick in some areas kind of loose red collagen bands.
Yeah, what should that make us think of, Esther?
Some kind of stromal, it's like cord stromal tumor. In some areas of the loose stroma versus the thick collagen areas. And then you have kind of round cells, kind of not organized, but in between the fronts of the stroma. What do you think? I think
Yeah.
that,
Yeah, so this looks like a sex cord stromal tumor. It doesn't look like it has really readily identifiable, Sertoli Leidig elements. So we're probably thinking something more in the order of fibroma or some other of those more stromal, pure stromal elements. And that is very helpful because that says to the surgeon, probably not something that's going to be highly malignant, not something that's likely to have spread. So they may take a more conservative surgical approach in that situation. Okay, let's see what else we got here to look
Yeah,
at.
just a quick couple of points on the prior case. So I agree that I would be in the fibrothecoma camp. And I think that we just something to consider. I've had a couple of cases where clinicians have gone in expecting a malignancy because the patient has Meigs syndrome, where you can have pleural effusion, and so the presentation looks clinically they're thinking malignant, and then you're getting this sort of a histology. So you just have to be aware that actually your histology explains their clinical picture. And also with thecoma, you can get sclerosing peritonitis, which is also mimics carcinomatosis. So that can be unnerving sometimes if you get that at frozen section. By the way, Louis, those slides are beautiful for frozen section. Whoever's cutting your frozens, can we borrow them, please? Or,
Heavens,
those are
no, we're
beautiful.
sticking, we're holding on to our histotechs as hard as we can. But yeah,
Those frozen sections are almost as good as permanent. So kudos to your histotext there.
I will pass the word along on that. All right, well, let's move to another very common type of pattern that we see on frozen section, and that is the sort of papillary cystic, mixed papillary and cystic lesions, where you've got, variable size cysts and some degree of papillarity, maybe involving the surface or maybe only very focally involving some of the cysts. And this most commonly is going to be one of our serous neoplasms, which, as you know, can be benign or borderline or carcinoma. And if it's the papillary cystic pattern, usually that's going to be a low-grade serous carcinoma. Now, other tumors, rarely mesothelioma or endometrioid tumors, can have this pattern. Some seromucinous tumors will also have this pattern, but these are all much less common than the garden variety of serous tumors. So when we're thinking serous tumors, then we have to kind of take a step back and say, do we know the criteria that we're going to use to distinguish these? In fact, the only really important distinction to make on frozen section is this one between benign and the rest. So if we can say it's benign, then they don't need to do staging. But any of these other categories, they're going to need to do staging biopsies. So sometimes we will sign out a case as at least borderline. And that's intended to indicate to them that they need to do staging sampling. So here is a frozen section example that fits into this category. And the low power evaluation here is, I think, very telling. Padmini, I'm going to pick on you. If you had this low power, would you be still thinking about a benign lesion?
No.
No, I wouldn't. I would definitely want to go higher power and look at some of those more blue areas. And see the nuclear features there. But even the architecture at low power is quite complex. So it's too much to be a benign.
Yeah, so this already is at least borderline. And so you've essentially been able to tell the surgeon already what they need to do next. And so primarily the pathologist on frozen section, your job is done at that point, although you can obviously evaluate this further and enjoy the thinking about what it might be. So borderline tumors have what we call tertiary branching. And that means 3 levels of complexity. So here's 1, here's 2, and then you can see the kind of the 3rd level as it becomes more micropapillary in some areas here. And by micropapillary, we're referring to just the very small tufts and so forth. That's in contrast to the designation of micropapillae, which is generally 5 times as long as it is wide. So this is probably fits into that category of a micropapillae. When that's extensive, that in itself tells you that it's going to be potentially behave more seriously than or more aggressively than just a benign or borderline tumor. Here's another example where you see primary branching and then secondary and some degree of a little bit of tertiary branching off of the side branches as well. So a nice example of, again, a very excellent frozen section slide that at low magnification, you're already got the answer on this particular case.
I'd like to just add one little thing, which is it may not be borderline in the sense that you can occasionally see serous cystadenoma with one small nubbin that looks like a borderline tumor. So if it's less than 10% of the total tumor, we would probably just call it cystadenoma with focal papillary proliferation or something like that. And those seem to behave almost entirely in a benign manner. So I think the one thing at least in our setup, one of the things that we've had potentially sort of errors in is that our readout area is actually physically separate from the grossing frozen section area. So the slide comes out and you look at it and you think it's borderline, you call it in as borderline. And then when the permanence comes out, it turns out that that's the only slide that has this pattern and everything else is benign cystadenoma. So one just needs to be aware of that at the back of your mind.
Yeah, that 10% rule is something to be mindful of, and that again underscores the importance of gross evaluation in your interpretations. So here's a gross image of what I would consider a mixed solid and cystic tumor. And this is really, I think, the most diverse differential diagnosis category of these gross tumors, because you can have certainly common epithelial tumors, high-grade serous carcinomas, endometrioid tumors, and so forth that have this mixed feature. You can have sex-scored stromal tumors that have this mixed characteristic. Some teratomas and even mixed germ cell tumors can have this appearance and metastasis. So you've got the full array of tumor types that can present in this sort of a gross appearance. And that makes this one of the more difficult ones to evaluate. Selecting areas for frozen section, it becomes very important in this sort of a setting. And I would say generally you want to include some of the solid tissue as well as some of the cystic elements. You want to try to avoid the necrotic areas, maybe the more yellowish or hemorrhagic necrotic areas. But anything that looks different from the rest of the tissue, you probably should sample. So more than 2 sections may be needed in a case like this to get a really good sampling of the different gross morphologies that are present. So here's a nice example. We have here some solid areas and then a more blue cell area up here. We'll take a look at some of the solid areas here. First, it looks like it's sort of a mixture of, fibromatous type of tissue, sort of wavy nuclei in a fibrous background. Nothing that looks terribly concerning. Here's our cystic element, and then here we have the epithelial component. And as you can see here, we have a combination of sort of goblet cell, mucinous type of epithelium, maybe with some other elements. And so in this situation, we've got a mixture of stroma and mucinous elements that would make us be concerned about possible metastatic disease, possible primary mucinous tumors. And it's also important to recognize that sometimes mucinous cysts can be associated with sex cord stromal tumors and other tumors. So evaluating all of these areas is important in that and getting the full picture. Here we have some areas of necrosis, which always is a bad sign. So, without coming to a definitive diagnosis here, I think in this sample you've seen that there is enough information to suggest that we need to be concerned about several other things, either a primary mucinous epithelial neoplasm or possibly even a metastatic neoplasm, potentially from the GI tract, given the number of goblet cells and the heterogeneity here. You see some of these more signet ring type cells in some of the areas. I think we have another example of this, or another example of a mixed tumor. Here's a more typical slide that we see, bad frozen section, a lot of stuff that sort of falls apart. But this is a very, very common element. As you see here, we've got a sort of cutaneous appearance. And so you'd know right away that this is at least a teratomatous element. So, could we have both of these? If these were two sections from the same tumor, we might be thinking that we have, maybe a neoplasm, secondary somatic neoplasm arising from a teratoma, or other type of possibilities in this situation. And I think here's another example of a more solid and cystic tumor. This one, I think, is a particularly challenging one because it's very difficult to ascertain the epithelial type here. You've got very complex papillary structures. It looks like a papillary serous neoplasm in some respects, but the cytoplasm is quite abundant. And so you'd even have to wonder about a seromucinous tumor or something of that sort. Potentially even because your nuclei here are fairly high grade, you'd have to be very concerned about carcinoma as well, either an endometrioid tumor with a seromucinous background or potentially even a high-grade serous carcinoma. Now, this would be one situation where the character of the fluid in the cystic spaces may be useful. In general, mucinous tumors have a sort of gooey, slippery type of cystic contents, whereas serous tumors tend to have a more watery, pale yellow fluid that flows out fairly easily. And again, so that's an opportunity where the evaluation of the gross specimen can guide you significantly in your evaluation.
Yeah.
Did you want to make a comment, Kamaljit?
Yeah, I was gonna say that I think just to stress the gross examination, I mean, I have made a habit that if a surgeon gives me an ovary with fallopian tube with ovarian mass, I always look at the fimbria. If I can see the fimbria, it looks okay, then I feel like, okay, I'm not probably dealing with a serous carcinoma. That's just one thing I think, because most of the serous carcinomas, I mean, they can come, you can have a serous that is not coming from the fimbria, but once I see a normal fimbria, I feel that, oh, okay, this may not be your typical high-grade serous. But yeah, just the importance of gross examination.
Yeah. Yeah, and that I agree completely. So let's look at another pattern, the so-called gelatinous tumors, which have this very glistening type of appearance. Maybe this might also apply to some fleshy tumors where you get a lot of extra fluid, and you can see here it's kind of leaked onto the towel as we've had it on the sample. This can be seen again with a variety of significant tumors. The struma ovarii, sex cord stromal tumors certainly can have this appearance. Metastatic mucinous tumors, pseudomyxoma, and also massive edema, which is a benign condition that presents as a large ovarian mass, sometimes in young or middle-aged women, and can be quite deceptive clinically in terms of suspicion for malignancy. And then some carcinomas obviously can have this appearance as well. So here is an example of this sort of a pattern, and you can see it's very, very pale because there's not much cellular content here. It's mostly very edematous tissue. And we've got some vascular structures. We have a little bit of stromal tissue here. They look fairly bland and benign. This is a case that ultimately proved to be massive edema of the ovary. And typically what you look for in that situation is a peripheral rim along the cortex and subcortical area of somewhat normal structures. But we don't really see too much of that in this frozen section. And that was part of what made it difficult to totally exclude a sex cord stromal tumor. Certainly there are cases where, fibromas or with massive edema, or even some sclerosing stromal tumors can have very edematous areas that look somewhat like this. But where everything looked this way and we didn't see any evidence of there being anything else, we considered this as possibly more consistent with massive edema of the ovary. Now, that is a diagnosis which, if you can make that on frozen section, it helps the surgeon. But even if you can't, if you say this is either massive edema or a sex cord stromal tumor with extensive edematous changes, more the fibrothecoma type category, that will be helpful and sufficient information to help them know kind of what to do next. Because you're telling them it's not a Sertoli Leidig tumor, it's not a epithelial tumor, it's not a metastatic disease. They can kind of stop with the removal of the ovary. Anyone else have any clues that they've used on massive edema cases?
I think the one other clue that helps with massive edema is finding like normal elements within the edematous tissue, if I were to find entrapped follicles in here, that would make me favor massive edema.
Yeah.
Mhm. I haven't seen a case of massive edema in the frozen, so I was gonna ask you, Dr. Hassel, is it uncommon? Is it, or have you seen few
It's relatively uncommon.
uncommon?
Yeah, I would say, if we see in our practice, if we see one case every other year, that would be about my expectations as far as that goes.
Mhm.
And that's where we're seeing, a couple of ovarian frozen sections a day.
Okay. Yeah. Because this look like some pink areas and some edematous areas. I think of Krukenberg. I mean, like I'm gonna go dive in and look for signet ring cells, and then
Yeah.
if I don't
Yeah.
see them, then okay. And some of these they look little, yeah. But so is it like related to torsion? Is that the etiology, or
As far as I know, it's not usually torsion.
is you
That'd be
okay?
another situation, yeah, where you think about that. And I think this is idiopathic as far as I know.
Okay.
Benita, have you seen any work on etiology for this?
No, so I'm actually glad that Kamaljit brought up the differential diagnosis of Krukenberg tumor. It's actually, I have made a mistake on a Krukenberg tumor and called it an edematous, either fibroma versus massive ovarian edema. And then the signet ring clearing, you do not see it very well on the frozen section. The cells actually the signet ring cells don't have their signating morphology at frozen section. So this is, I have made that mistake calling an ovarian tumor sort of favoring a benign sex cord stromal tumor versus massive edema, and then on permanent sections, the lesion turning out to be a Krukenberg tumor. And so that's a definite pitfall. I'm glad you mentioned it, Kamaljit.
Yeah. Yeah. Yeah, they don't flaunt their signet ring appearance. They almost look like histiocytes or foamy cells, so can be difficult. And I think I don't know if the gross can help in that setting, bilaterality or size. I don't know how big the massive edema can be.
So I think, massive edema is usually under 15 centimeters, more probably of an average of 10 centimeters or so.
Mm.
And Krukenberg's, I think, can be in that same size range. So I don't think size is a good differentiator between those. Age may be. I think if you had an older patient, that would be much less common to encounter massive edema. But if you've got someone in their 20s, somewhere in that, maybe the early 30s, I would probably lean more towards, massive edema than jumping towards Krukenberg.
I think the other thing, bilaterality helps. Massive edema is typically unilateral.
Exactly.
Metastatic tumors are typically bilateral. So,
All right, let's take a look at the fleshy category quickly. I'd like to save a few minutes for the cases that we've prepared as well. In this situation, a fleshy tumor, of course, you're thinking of small cell lymphoma in that category. Some of the carcinomas, of course, they'll be more heterogeneous with necrosis. But again, you've got the full range of lesions here to be considered. So the gross appearance here doesn't really narrow things as much as you would hope for. Whoops, got two copies of that slide. Here's an example of a case that was quite fleshy, and you can see it's got a lot of blue cells here. There are a lot of pleomorphism, big cells, little cells, clustered in small groups. This is probably in an older patient, you would be thinking, oh, this looks like a high-grade serous carcinoma. It doesn't have any other differentiating features and so forth. And I think if you made that diagnosis, in some cases, almost preemptively without even the supporting immunohistochemistry, you'd be spot on. Here's another example of a case in this category. And I believe this was a small cell carcinoma. I don't recall exactly, but again, you can see it's very cellular, very high grade appearing neoplasm. And so you don't have to make the specific diagnosis. As I've mentioned, you just need to say, okay, we've got a high grade cellular neoplasm. It looks epithelial or epithelioid at least, and she needs further staging and definitive immunohistochemistry to define the nature of this tumor. So I'm going to stop at this point and Esther, let you and others sort of take the lead on some of the cases that you've got from real life stories to discuss.
Should we break out into a smaller room or
Well,
15 minutes or so, or?
Sure, we could do that. Felicity, you want to send us off into 2 different rooms?
So I think Minnie has a case. Do you have, yeah, and then I have a case of 2 rooms.
So Minnie and you should be in the separate rooms.
Yes.
While we're waiting, does anybody have any questions?
I want to say that, and Vinita already said that those are really good cases, Dr. Hassel. That's a good collection there.
Well, frozen section diagnosis has been one of my passions of trying to teach our residents, and I think it's one of those skills that you just never get enough of in training. So,
I have a frozen from yesterday and I'm almost embarrassed. I cut it myself, but we'll see how it looks. Okay. Shares. Okay. So I'll give you a little bit of context for this patient. She's 20 years old, and she had a 1.5 centimeter cyst in her ovary. Her ovary itself was maybe 3 centimeters. So tiny cyst. They went in and the surgeons went in and thought they could just take out the cyst because she's so young. That's the goal. We can't really biopsy these things, but they want to just remove the cyst to preserve fertility. But when they went in there, they unfortunately had to remove the whole ovary just because of the nature of the cyst itself. So I can't show it as a whole slide, but I'm going to go around the entire tissue just so you can see what we're looking at. And this is much more realistic for my that I'm doing. All of this tearing and shattering of the tissue, which I'll get into explaining why it happened there. And then we'll go up around and it connects down over here. Okay. So I'll start with the normal. This is normal ovary. And you can see this is the outer surface. So it looks pretty simple, benign, single layer. And this is ovarian stroma. You see that cellularity. So the lesion, when I think about it, it's not in the epithelial portion. But as I scrolled around, the stroma goes from that blue and it starts turning into something more like this. That transition into it's like a lot more pink, a lot more clear. Higher power. This is a good focus. I guess we can call on maybe 2 or 9. I've heard. So maybe I'll pick up. Can you describe what this stroma looks like to you?
For me, process. Okay. I think background is a proliferative small group of cells with a loop stroma. I think benign lesion.
Yeah. What makes you go into benign?
Because not more cells is a homogeneous, not proliferation or the AGP, no mitosis. Okay.
But there's
No stroma, dismal stroma.
Mhm.
Okay.
Mhm.
I think benign.
Yeah. And that's essentially what they need at frozen. They just need to know, is this benign or is this malignant? Because
Yeah.
she had to decide whether she was going to do a lymph node staging at this point, the surgeon.
Yeah.
So we can comfortably put it into that category. But what I think is interesting, and this is what I think it will be, we'll see when I get the permanence, if this is what it ends up being. See how within a lot of these cells, there's tiny little cleared out, vacuolated spaces. These little white areas. That's not normal in ovarian stroma. And so I think this might actually end up being a steroid cell tumor. And that's something that what Dr. Singh was saying, the gross, I'm going to actually switch my screen. What actually?
Was that part of the reason that they had to resect the whole ovary was because of the location? Was it in the hilus?
Yep, exactly. And that's actually, I can go back to, I'm just trying to get to the right. So this is what the location, so it's in the center. They can't really take it out because there's not much ovarian stroma left out here. And then on top of that, see how like yellow and almost sometimes necrotic looks like this. Usually necrosis is more bright, light yellow. This is that orange yellow, kind of like an adrenal gland, which fits with steroid cells, these hormone producing tumors. So that's exactly why they had to take it out. And to point that it's in the hilum, I'll go back to the slide itself. You can even see that on the microscopy. If we go to here where the tumor is, just going up further, you see all of these big vessels, and that kind of tells you that you're in that hilum region. And so piecing together what the gross looks like, the location of the tumor, and the patient's age, that's also, it's probably going to be something benign in a 20-year-old. Yeah, I think it's a nice piece of a steroid cell tumor. The other thing to think about is a pregnancy luteoma, because they can look very similar, but those typically occur in the 3rd trimester. So if they had told me that this patient, I mean, usually we don't see those half frozen. Sometimes they're going in after a C-section and they take it out. But, those are just things to think about. And like you said, no significant mitotic activity, no significant atypia within the nuclei, and not really a lot of necrosis. Those are all good things that point me into the benign metabolism. Yeah. So yeah, that's the case I have.
Minnie, how old was the patient? I'm sorry, I missed that.
He was 20
That's unusual.
for this young, right? Yeah. And
Yeah.
I have to look in to see if she had any of the symptoms of like viralization or anything that would go along with that. What do you think of something else for this age?
No, so I think that well, I would be concerned about this is a case where I would ask the clinician about imaging information, because if the patient is that young, even just a follicular luteinized corpus luteum can get up to 2 centimeters.
Right.
So
Yeah.
I think you're absolutely right. The gross is really important with respect to the location of the lesion. And also, I think the imaging findings, I mean, the imaging findings can inform on sort of vascularity and all of those structures. In a young patient, in an older patient, this is a fairly straightforward diagnosis because corpus luteum is just not in your differential. It looks very solid, so that also makes me think of tumor. But depending on your cut of the corpus luteum, if you're cutting perpendicular and don't get the central portion, it can look very, very solid. So
Yeah.
it's a good call. And I guess, I don't know whether you could see it on frozen section or not, but you often see lipofuscin pigment
Yeah.
in the steroid cell tumor. So that is not something that you see with a regular or persistent corpus luteum. So interesting case.
I think it is. I asked her, because when I first looked at it, my thought was, okay, it could be steroid cell just because it's very orange. But I even discussed that like this could just be a corpus luteum cyst. And I asked her if she wanted a frozen, and she did. And so then this was a nice little finding. And we'll see what I end up getting for the permanent. But it's a great point. I don't see any pigment in this section. For her. So, well, it's a cool case. I'll have them put the whole thing through since it's not so big. But yeah. Thank you.
Jeannie, when would you draw the distinction between, an adrenal rest or
Ah,
steroid cell rest versus calling it a tumor?
an actual tumor. I think that's a great question. For this one, I think that my experience with the adrenal cortical rest or even like ectopic adrenal tissue is you'll have more layers to it. This is kind of that homogeneous look of the microvesicular nucleated cells versus with the more adrenal rest, I would see other layers of the zona. I don't know if that's